First, I'd like to thank Dr. Borba for the invitation. And this morning, I will be speaking to you about extended endoscopic endonasal approach to clivus chordomas and chondrosarcomas. The endoscopic surgery to clivus region is an extended approach that provides improved visualization and is a superior alternative for transscoping cranial surgeries in most cases. Now, I'd like to show you a quick overview regarding surgical clivus anatomy. For endoscopic surgery, the anatomical knowledge of this sphenoid bone is essential, and its relationships with cranial vessels and nerves. Once the sphenoid rostrum is removed, the path is open inside to the sphenoid sinus to see, for the visualization, the skull-based structures, like the clivus and the other structures around it, like the pituitary gland, the bilateral carotid arteries, the carotid recess, optic nerve, and plenum. Removing the bone, we can see the dura mater cover the posterior fossa, and the bilateral paraclivus ICA that are the lateral surgical limit of the clivus surgery, and superiorly the pituitary gland. Behind the dura, we can see the neurovascular structures of the posterior fossa in the upper, medial, and the lower clivus. Now, I'd like to show you Mercado Brasil Barreto's video for a cadaveric dissection, where we can see these neurovascular structures in the upper clivus, the pons basilar artery, superior cerebellar arteries, posterior cerebral arteries, and third nerve. In the medium clivus, the pons basilar artery, the bilateral icus, and the sixth nerve goes to the doralus canal. And in the inferior, in the lower segment of the clivus, the medulla oblongata, vertebral arteries, and in the paraclivus region, the cranial nerves, 9, 10, 11, and the 12th nerve. Regarding clivus surgery, endoscopic endonasal approaches have advantages and risks. Regarding advantages, it's endoscopic surgery is a vitral and direct access to expose the clivus to reach deep tumors like chordomas and chondrosarcomas. This approach avoids brain retraction and major vascular and neural manipulation, and reduce the incidence of cranial nervous palsy, and facilitates wide tumor resection. Regarding risks, CSS leak when the dura mater is opened or infiltrated by the tumor, and infection that is frequently associated with CSS leak. It's important to preserve ICA and cranial nerves in this approach, and it is also important to avoid nasal morbidities to improve the post-operative quality of life of the patients. I use the binostrial. I use the binostrial access to the clivus. The nasal septal flap is made in one size. After we removed the vomer and opened the sphenoid rostrum to go inside to the sphenoid sinus and to see the skull base landmarks. Regarding surgery for chordomas and chondrosarcomas, now I'd like to show you our experience about this approach. I divided the cases in tumors with a lateral extradural station, and dural and brainstem infiltration. The endoscopic surgery is advocated by several authors to approach extradural midline tumors. In my opinion, is the best indication. This is the first case, extradural midline tumor. This surgery I performed this month. Inside into the nasal cavity, we can see the tumor here. In another side, the tumor. This is the tumor resection into the sphenoid sinus. Here, you can see the carotid artery, the paracellar and paraclavus region in the dissection. This is the clivus bone tumor resection with